Standards of care have continued to evolve as we accumulate more data to support the use of immuno-oncology agents in advanced non-small cell lung cancer. Busy oncologists have an expanding number of therapeutic options from which to choose when formulating a treatment plan for each patient. In this OncLive peer exchange discussion, my colleagues and I will look at the challenges in finding the right systemic treatment for the right patient. We'll talk about the data from the ASCO 2019 annual meeting and how it relates to the treatment of advanced disease. I'm Dr. Mark Sosinski, Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. Joining me today on this distinguished panel are Dr. Christian Higgins, Associate Professor, Department of Radiation Oncology at Emory University School of Medicine, and Medical Director of Radiation Oncology at the Emory Clinic in Atlanta, Georgia. Dr. Corey Langer, Director of Thoracic Oncology and Professor of Medicine at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. Dr. Tiziana Leal, Assistant Professor in the Department of Medicine, Division of Hematology Oncology at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. Dr. Paul Pack, Clinical Director of Thoracic Oncology Service at Memorial Sloan Kettering Cancer Center in New York City, New York. And Dr. Heather Wakely, Professor of Medicine in the Division of Oncology at the Stanford University Medical Center and Faculty Director of the Stanford Cancer Clinical Trials Office in Stanford, California. Thank you, and let's begin. So Corey, I'm going to start with you. We're going to start with stage 3 disease. You as the senior member of this panel. And talk. There are two things that I've said to fellows over the years in residents that we train. There are two things you absolutely have to get right in every cancer patient, particularly lung cancer, and that's the diagnosis and the stage. So I want to talk about stage 3 and staging and kind of what your typical workup is and what your thoughts and concerns are in the initial approach to making sure you really have a stage 3 patient.
Sure, Mark. Standard staging includes CAT scan, of course, CT of the chest. For most stage 3 patients, the vast overwhelming majority of bronchoscopy and EBUS to establish nodal architecture and nodal involvement. There's a world of difference between 3A and ipsilateral nodes versus contralateral. And in this day and age, particularly in developed countries, PET is routinely used. And just from the get-go, taking a patient who otherwise might have stage 3, based on CT alone, anywhere from 15 to 20% are likely to be upstaged to stage 4 with PET on the basis of otherwise occult metastatic disease. So those folks in the past would have been treated with low combined modality, and frankly, we're not doing them any favors.
In the brain?
Brain scan as well, MRI of the brain routinely. And that too is a shift from the past. We're old timers, me a little bit older than you by about 6 months, but there was a time when we just did CAT scans. We didn't have MRI, and needless to say, probably another 15 to 20% are upstage.
Yeah, and often clinical trials would say if clinically indicated.
Right.
So we'd have
pretty much in our clinic, it's always indicated.
Right, right. So I think you made a good point about a pathologic confirmation of the mediastinal nodes. I think that's an important aspect of staging, to make sure that what you see on CT, what you see on PET is actually a confirmation of disease. Tiziana, your thoughts. Often what can happen, and I think we all experience this, is that sometimes it takes patients a while to get to us. And so you're sitting there, someone may have done a CT scan, may not have done a PET, or maybe did do a PET, and it's, say, 3 months ago. When do you think that it's appropriate to rethink the staging in that situation?
Yeah, I think certainly the timeliness in lung cancer care is something that we always think about, and there are no really set and defined timelines that are the most appropriate. But occasionally when you have that patient who comes in and they've had a PET outside and it's just taken them a while to get to your clinic, and now they're 3 months out, they certainly need to be restaged. So a repeat PET scan is certainly indicated in that situation. When is sort of the cutoff, I think, is the most challenging question. I think a lot of times, especially with our radiation oncologists, we have that discussion. And I would say clinically, it's about 4 to 6 weeks where we start to feel uncomfortable, worry that perhaps things have changed. There isn't great data to support that, but I think it's a clinical call at that point.
It should be driven by if patients are becoming perhaps more symptomatic or may have new symptoms that you may want to rethink doing it.
Right. I think that would be something that would be an easy call to do if something somebody has symptoms that are suggestive of advancing disease. But I think also patients who are not having advancing disease, I mean, you can have progression of nodal disease, progression of their disease even without symptoms. And I certainly would worry that patient might need a change in their care if we identify something new at that point.
So, Kristen, from your perspective as a radiation oncologist, your thoughts about staging and what do you think through in terms of what you plan?
Yeah, absolutely. So the timing of the PET is really critically important for the design of optimal radiation treatment volumes. Many times as a patient is progressing through their disease, the parenchymal primary tumor can grow, the extent of nodal disease can grow, and we really only cover PET positive disease. So having a accurate PET is really important when you're designing your radiation volumes. We try to keep our radiation treatment volumes as reasonable as possible as to not increase toxicity. So we don't want to make them larger if we don't have to. So that updated PET information can be really important and really helpful.
Exactly. So are you along the same timeline?
Yes.
In terms of
Yes, absolutely. 4 to 6 weeks.
Is PET kind of a standard now in terms of radiation planning? Would you agree with that?
Mm-hmm.
Okay.